Okay, so we'll try to review some of the aspects of the LV function. We'll review the anatomy, of course. I think it's not going to be new because we've been speaking a bit since the beginning of the year about like the different configuration of the ventricles. We'll talk about some of the echo markers of function, some that are like obvious systolic, diastolic, which is a bit more complicated to kind of evaluate in the newborn period and even in the pediatric period. It's a bit of a kind of an esoteric field, I would say. We'll talk about the combination of RV and LV crosstalk when there's normal configuration of the heart. It becomes much more difficult when there's not normal configuration of the heart. And because we're not doing a cardiology fellowship, we're not going to go into that. But I think you have to keep in mind that if the LV is connected to the pulmonary artery, like in transposition, um, the function is obviously going to be very load dependent because if it doesn't have to bench press a lot, it's not going to be very hard for the LV to pump into a network that has vascular resistance that are very low. Same thing, all these ventricular markers of function are often going to be load dependent in a sense. Um, it's going to be affected by your preload. And so your LV preload is coming from your pulmonary blood flow, plus or minus some contribution of the interatrial shunt. So if you have a massive right to left shunt at your atrium, obviously it's going to contribute to the LV preload. And similarly, if you have no pulmonary blood flow and trickle amount of pulmonary venous flow coming back to your LV, that's also going to affect the preload. And if your LV is completely underflated and is not containing any blood flow, it's just going to, try to pump in an empty cavity. And we'll talk about the properties of the muscle itself, because obviously the muscle, depending on how big it is or how constricted it is, if you have like a tamponade, for example, its preload might be affected too. And we'll talk about some diagnosis. We'll go over questions. So let's review a bit the anatomy. So when we talk about function, we always need to say what do we mean about function? I think we can have patients that are compensating by various mechanisms to maintain what we call perfusion, which is like the matching between the metabolic demand and the oxygen delivery, as well as the energy substrates delivery to the tissues. And of course, function is part of this whole process of trying to eject blood flow into the outflow tracts of the systemic circulation and eventually distribute this blood flow in a way that is going to match the demand. And if the body senses that you don't match that demand, there's going to be compensatory mechanism to try to address this. So you could be increasing, for example, your heart rate to increase your cardiac output if your stroke volume is very limited. You could also adjust by autoregulation various resistance profile in some of your tissues, which could also impact oxygen delivery. And obviously, your oxygen delivery will also be affected by properties that are unrelated to the cardiovascular system. So think about the hemoglobin dissociation curve. Think about the quantity of hemoglobin you have. Think about, if you take a patient and you start obstructing airways, well, obviously oxygen delivery to that hemoglobin will be impacted. So there's all these things we look at when we see our babies that are seem to be badly perfused. And one of the things we assess, especially using TNE, is trying to understand how much is the inherent inotropy or inherent contractility of these ventricles, and the LV being most often your systemic ventricle. We're very interested in better understanding how much this is contributing to the poor perfusional state that we have. So the LV function is dependent on its architecture. Thankfully, we deal with ventricles that have, no congenital heart defects. So that's definitely something that makes our life a bit easier. Number two, it does depend on the crosstalk between the right and the left ventricle. So as you can see, they have shared muscle layers like the septum, and they have shared layers also between the two ventricles. So when the RV starts struggling for various reasons, let's say significant pulmonary hypertension or RVOT obstruction or pulmonary emboli, eventually, first of all, you're going to send less blood flow to your pulmonary vasculature. And so because of that, you will underfill your left ventricle because the LV preload is dependent on the pulmonary blood flow. And number two, this RV that can become very pressure overloaded can start impinging onto the LV. And so the septal configuration might start to kind of block the LV filling because it becomes so overloaded that your LV can become pancaked. So there's a lot of that happens. And then there's also all this aspect of activation of the conducting system. So think about the fact that you have electricity going through these muscle layers that are actually activating the LV and the RV. And of course, if you start having fibrosis here, fibrosis here, fibrosis here, or if you have arrhythmias or dispersion of electricity that becomes a problem, then it can be part of LV dysfunction. So we see patients with like intractable SVT, patients in TGRT, or patients who had previous like zone of ischemias of their ventricles because of various conditions like asphyxia, or if you think about patients who have coronary steel, or patients who have prenatal inflammatory changes to their LV. So lupic mothers may have pregnancies affected by autoantibodies that circulates into the baby, and that can affect both the conductive system but also the myocardial wall. And it's very described that they can develop like certain degrees of cardiomyopathy, and they get something called EFE, so endocardial fibroelastosis. And basically on echo, it looks like very, very bright because it's areas of fibrous tissue and it's very echogenic. So it rebounds a lot the ultrasound waves. So you see these like very bright white layers around the muscle, and that's not muscle tissue. So first of all, it doesn't conduct electricity. On top of it, it doesn't participate to contraction. And then finally, to add to the complexity, that's more seen in the adult world, but we can sometimes see it in patients who have some degree of coronary changes. But you can have what we call dyssynchrony. And what's dyssynchrony? It's like basically we're not dancing on the same rhythm. We're like part of a dancing troupe, and I'm going to the left and everyone's going to the right. That's a big problem. So, same thing, electricity could be dispersing in an abnormal way. Especially in LVs that have suffered. And that's why we often see in these patients who had even mild degree of acidosis, some degree of cardiac dysfunction, because acidosis is very toxic for the myocardial cells and for the conducting cells. And so you get all of this dyssynchrony and poor contraction. And so when you're looking at a patient who have bad inotropy or bad contractility, think of these things. Could there be also a component of electrolytic disturbances? Is there acidosis, or is there a problem with my calcium levels? So you'll see me each time I see HIE babies, because they often have poor LV function or poor RV function. That's the one of the first thing I look at, like what's their calcium? Do I need to give a calcium bolus? So function in general is composed of classically what we call two cardiac cycle phases. Number one, you have the systole, which is the contraction, which typically, if you're an adult, you spend 1/3 of your time in systole. And then you have diastole, which is relaxation. And relaxation is an active process. And at the end of the relaxation, you hear a lot of noises on the bend level. Yeah, sorry. At the end of diastole, you get to your maximal filling, and this maximal filling is partly inherent to how much these fibers are able to stretch, like a bit of balloon that you're stretching, but it's also dependent on how much you're putting into this cavity. So think of a balloon, it has an inherent capacity to stretch, but then it depends on how much air you push into, and at some point it will pop, right? It's not able to stretch anymore. So diastole is composed of these different components, and that's why it's quite difficult to assess in neonatal life for various reasons. But the systolic part is often the part that becomes a big problem in our patients. This can become a problem in like patients with like infant of diabetic mother with severe hypertrophy, exposed to steroids, severe hypertrophy, patients who are hypertrophic cardiomyopathy, severe hypertrophy. So that could be a problem. And on the right ventricular side, we'll talk at another time, but obstructive lesions can cause this at the RV side. Same thing if you have an LV who have like aortic stenosis, then obviously the LV can maladaptively become hypertrophic. And, on top of having the obstruction, which limits your blood flow in your outflow tract and creates a situation of high stress level in the myocardial wall, which eventually you get a failure of your LV. You can also have maladaptive response where it becomes very hypertrophic. But thankfully, again, this is often kind of more of a cardiology question than for us, where we don't really deal with fixed obstruction. What we might deal with is what we call dynamic obstruction, where you have hypertrophy of your septum, like infant of diabetic mother, and during contraction, because it's so bulky, you get narrowing of your outflow tract and acceleration in this outflow tract because of that. And so then you need to figure out, what am I going to do to try to deal with that? How can I promote the relaxation, or how can I promote stenting this dynamic obstruction? And so we'll have a session on hypertrophy and some of the management like beta blockers or vasopressors to try to stent the outflow tract. So we'll try to concentrate mostly on systole today. As you know, the more your ventricle is struggling, the more it takes time for the ventricle to actually eject. And so systole becomes longer compared to diastole. It's one marker of cardiac dysfunction. So we can sometimes measure the time you spend in systole based on like MR versus the time you spend in diastole as an indirect marker of cardiac performance. And the other problem we often get in babies is that one of the main ways to compensate for poor cardiac output due to LV contractility issue, which translate into limited stroke volume, is by increasing heart rate. And as you increase your heart rate and become very tachycardic, you have much less time for your filling period because I just told you the systole becomes more prolonged. And on top of it, you have fast heart rate. So this diastolic period becomes very impaired. And then you can start impairing your filling period and becomes a big issue. So anatomic consideration, the LV and the RV don't have the same shape. We reviewed this a few times already, but it has more of this bullet or conical shape in most of the patients. It has a very smooth septal surface on the LV side compared to the RV side, which is much more trabeculated. It has very fine coarses trabeculation at the apical level compared to the RV, which is much more coarse in terms of its trabeculation. You see that the mitral valve here, which is in the background, is bicuspid, and that its attachment goes to papillary muscles that are never attached to the septum. And then finally, you get what we call a continuity in the fibrous structures connecting your aortic valve to your to your mitral valve. So we call this mitral aortic continuity, versus the tricuspid valve and the pulmonary valve are not even on the same plane for the right ventricle. The LV is in general a ventricle that becomes much more muscular in the postnatal stage once your SVR rises and that your aorta has to send blood flow in the systemic vasculature, which is much more diffuse. And so because of that, the afterload is much higher for the LV. And so the adaptive process makes it that it becomes a much more powerful and muscular ventricle that is able to generate more pressure in the system so that the flow can be distributed across this entire vasculature. And similarly, the left atrium and right atrium are very different. So left atrium has an appendage that looks like a finger versus the right atrium has a appendage that looks like a pyramid. The interventricular septum have fibers that are connected together. And what else? That's pretty much what I wanted to say about that. The LV is obviously perfused by coronaries. These coronaries are typically perfused in the diastolic phase of the cardiac cycle. And so we typically have a left coronary descending artery and left circumflex artery. They supply different segments and different areas of the heart. And obviously you can have coronary anomalies that may impact your LV perfusion. That's more the realm of our cardiology friends, where they can face disease like Al-Kappa, for example, where the coronary artery comes out of the pulmonary artery and creates issues with myocardial perfusion. What we see in functional diseases is issues where your coronary may not be well perfused. So think about like lesions that will steal from your coronary. So large PDA could potentially do that. Patients with a lot of steal and like vein of Galen malformation or other types of lesions like aortic insufficiency. And then the venous drainage typically will occur to the coronary sinus, which typically will go to the right atrium. And there's a small little valve that's called a Thebesian valve, which will close off the coronary level. And obviously, if you start having high right atrial pressure, eventually your coronary sinus, which drains into the right atrium, could face a higher RA pressure. And because of that, your coronary gradient may start become impaired. And so if you have low diastolic pressures in your aorta and high right atrial pressure, your transcoronary gradient can become a problem. And that's why sometimes when we see very low diastolic pressure in like conditions like septic shock and things like that, it can be part of the equation of why this patient has poor LV function. So we try to address this. we try to compensate by aiming higher diastolic pressures to maintain coronary perfusion. So I've put here some of the consideration about the LV and the RV and their differences in terms of, the different aspects of papillary muscle, volume, mass, etc. We went over some of these things. Some of the reason why we call the mitral valve a mitral valve and not a bicuspid valve is this. It's because the hat of the bishops is called a mitre, and the mitral valve is called a mitral valve because of this shape.
Can you give us 1 second?
Yeah. Ben, should I continue? Or you have, yeah? Okay, perfect. And so the mitral valve is typically has two papillary muscles. And generally you have the anterior lateral, which connects to the anterior leaflet, and you have what we call the posterior medial, which will connect to the posterior leaflet. These leaflets, these leaflets of the mitral valve can also be abnormal. So you can have a lot of insufficiency of the mitral valve. You can have mitral valve cleft. So that should be referred obviously to cardiology. Patients with atrioventricular septal defect don't have a mitral valve. They have what we call a left-sided atrioventricular valve and a right-sided atrioventricular valve. So in cardiology, they'll look at the conformation of these valves to see how they're going to be doing the repair. Finally, papillary muscles can be a problem because you can also have in some congenital heart defect something called a parachute mitral valve, which is basically all the tendons come to a single papillary muscle, and it really looks like a parachute, and that can cause mitral valve stenosis. And there's other elements about parachute, and I'm not an expert in that, but if you're interested, there's like many chapters on Sean complex, which has typically a parachute mitral valve. So I've put here the segmentation of what we see in the apical 4-chamber, 2-chamber, and the parasternal long axis, or the apical 3-chamber view. So you can see here that here we see mostly the septum and the anterolateral wall. Here we see the posterior or inferior wall of the left ventricle and the anterior wall of the left ventricle. And in the kind of 3-chamber / parasternal long axis view from the apex, we see what we call the inferior lateral or posterior lateral wall and the apical anterior or anteroseptal wall. So this is more of the septum, and you see a bit of the RV, and this gives out to the kind of LVOT. And when you're looking at the short axis, you're basically cutting the LV at all these levels. So this first level, this second level, and this third level, and sometimes we can get up to the apex. And so that's, basically the representation from the view from on top of these three views. So ASC has different models of how to classify these different segments. In neonatology, it's not as frequent that we will speak into segments compared to like the adult world, but in the adult world, they have coronary artery disease that may impact specific segments of the ventricles, and that's why it's important for them to understand which segments particularly are being affected. It helps them understand the degree of the coronary artery disease before going to the cath lab for kind of revascularization treatments. But in neonates, you could also have segmental issues. So sometimes the septum might be more impacted than the rest of the ventricle, or some areas may be more impacted than others. And so it's kind of important to have in mind this topography. So typically what we use is the either 16 or 17 models. And these models are basically the representation of what's kind of the divisional here, or the 18 segments, which basically kind of creates this topography of the ventricles. And I put here, how it would look like on 2D echo. So why it's important, I just mentioned it. There's different, perfusional territories by coronary arteries. And so that's why when we look at some very specific segmental anomalies, it could be related to some of these different perfusional states. Okay, so cardiac function, the LV will contract mostly what we call circumferentially. So it means towards the inside. So that's why a lot of the markers of function are actually designed to represent this circumferential contraction. There's also an element of what we call torsion or ringing movement. So in French, we talk about like essorage, if we're like really having like a towel that we're turning. Sorry, I cannot see. Is my camera working? Yes. Okay, perfect. Um, so you get a component of shortening towards the inside, which is the circumferential strain. You get a component of a thickening of this muscle. So the more it thickens, the more it's going to compress the internal cavity. And then you get a small component of the longitudinal aspect of the function on the LV, which is very different than the RV, where a lot of the fibers are arranged longitudinally and its component of longitudinal function is much more pronounced than the LV. So the walls get thicker. It's what we call the radial contraction. And then you get this kind of clockwise and counterclockwise rotations at the base and the apex. And so that creates this kind of motion from the apex towards the outflow tract during contraction. To add to the complexity, and it's not something that we can really well characterize by 2D echo, you can kind of characterize it using 3D echo with some of the algorithms that are commercially available. But really, it's a lot of work being done by kind of MRI that you can characterize the torsion and twist of these ventricles. But you can see that the fibers are actually organized very differentially across the different layers. So really, the subepicardial layers versus the subendocardial layers are not necessarily rotating the same way. And you can see this represented here, where you kind of get twisting at different levels, allowing to perform this circumferential contraction and the rotational contraction. And so more and more, we realize that there could be some subtle changes early in the heart of some patients that are only detected in some of these metrics of rotation. But I don't think it's yet prime time to include that in kind of clinical pathways. It's definitely something that we do in the research lab, but not necessarily something that we do in the clinical world. So I put here, if you read articles on research, neonatal research of LV function, you're gonna see that sometimes they talk about the twist. The twist is basically this apical rotation versus the basal rotation, and this is expressed in degrees of rotation, how much it rotated during systole from the apex and how much it rotated at the base being the zone where the mitral valve attaches. And the torsion is this value normalized to the length of the ventricle. Why? Because if you have a very tiny ventricle versus a really big ventricle, the amount of rotation you have might be a bit kind of different in the sense that a smaller ventricle may have a bit more restriction in its capacity to rotate at the two extremities. So at the end of the day, in hemodynamics, what we're interested is the absolute amount of blood flow distribution and the capacity to match the distribution of blood flow and oxygenation delivery to the metabolic demand, so the tissues are not becoming ischemic, hypoxic, and eventually they get necrosed. The other thing you want to avoid, and that's another field of hemodynamics, is reperfusion injuries. So you don't want to overdo things. So that's why you always have to be careful. So more is not necessarily better. And so it's that tight kind of window of matching that's important to consider in some of our patients. And how do we titrate some of the medication that we give to avoid creating more injury or not providing enough blood flow to rescue certain types of phenotypes. So you've seen this curve. It's basic physiology. This is called the pressure volume curve. And this is for specifically the left ventricle. How I know it's for the left ventricle is because I put mitral and aortic, but you could potentially put the same curve and have what we call the right ventricular pressure volume relationship, where you would have tricuspid and pulmonary valve in a normal heart configuration. And so here you can see that basically your stroke volume is the amount of volume that you have between your end diastole and end systole. And then you get a moment of contraction where during that contraction, you have a portion of what we call isovolumetric contraction, where the LV volume doesn't change because the pressure in the LV is building up, but it's not yet bigger than the aortic pressure. Once it reaches the value of being higher than the residual aortic pressure, you end up in what we call an ejection phase, where your LV volume will decrease up to the point that is the end systolic volume. And at that point, you reach a point where your aortic valve closes because the pressure in the LV is already decreasing and becoming lower than what's happening in the aorta. Your aortic valve closes, and if it's competent, it's going to maintain diastolic pressure in your aorta, but the pressure in the LV will drop significantly as this LV is expanding. And so you do get a portion of isovolumetric relaxation where the volume doesn't change, but the pressure in the LV actually drops significantly until your pressure are so low that your mitral valve is opening because the LA has a higher pressure than what's happening in the LV. Eventually, your mitral valve opens, you start getting your filling. Technically, you should see a little blip during the atrial contraction, and eventually you'll have the end diastolic volume, and you repeat this cycle unless you're dead or you're on a mechanical pump. So that's pretty much the pressure volume relationship. You can also outline the relationship during the various phase as per timing. So this time you have time on the x-axis. So here you had volume on the x-axis and pressure on the y-axis. Here what you have is you have time, and you can have both the pressure or the volume represented. And basically what we just reviewed is actually here. So you see end diastolic and systolic volume, the period of ejection, the period of filling, and the moment that you spend in the isovolumetric portion of the cardiac cycle. And then on top, you can see what's happening to the pressure curve. And as I just mentioned, your green curve is the left ventricular curve. So if you had a cath lab, you could go in the cath lab and actually represent these curves as you're progressing through the trajectory of your heart. So you would start with the left atrium, which has in general these very tiny pressures. And eventually you enter the LV where you see the curve into the left ventricle. And eventually you go through the aortic valve and you can measure, well, you probably not go through the aortic valve. You probably put your catheter in your femoral artery and then go into your aorta and then see kind of your aortic pressures. And so these values will become very dependent on what's happening at the LV side or what's happening at the left atrial side. But of course, what we measure at the bedside when we put a cannula is just this curve, which is the aortic pressure curve. And so if you have tons of aortic valve insufficiency, you're going to see that this diastolic pressure in the aorta is going to drop significantly. And the diastolic pressure in the LV will be a bit higher because you're stealing a lot of volume inside your LV. Similarly, if your LV is not able to generate sufficient flow, the pressure in systole will start dropping, and this will also affect your aortic pressure because obviously they're dependent on what's happening in the LV. So this graph should kind of be in your mind when you're assessing patient, and you should be looking at what are the problems? Do I have problems with my valves? Do I have problems with my filling? Do I have problems with my contractility? Do I have problems with the activation of my heart? So the end result in systole and diastole is represented by this beautiful graph, and I put a reference downstairs here, which basically you have a component of rotation, you have a component of longitudinal contraction, and you have a lot of component of this circumferential contraction plus the radial thickening. They're all part of different properties of the LV that are allowing you to end of the game generate flow in your system. So my cheat sheet, when I find that the cardiac function might be impaired, well, first of all, I look at do I have concern that there might be too high of an afterload? So is my patient hypertensive or SVR that could be too much increase, and because of that, the LV is having an issue. I look at is the muscle healthy? So do I have problem with oxygenation of my muscle, hemoglobin transport, blood flow to coronaries, coronary steal? Do I have issues at the level of the cells? So do I have problem like genetically, like Pompe Noonan, inflammation, fibrosis, post-ischemic fibrin deposition? Do I have issues with nutrients? So is my baby hypoglycemic? Do I have problem with glucose control? Do I have problems with arrhythmias that burn the stores or increase oxygen consumption? Do I have any electrolytic imbalances that could be causing issue to my cellular activation? Then the electrical system activation. Do I have issues like arrhythmias or spreading of electricity? Is my afterload needs to be within reasonable limits? So if you have coarctation, hypertension, aortic stenosis, interrupted aortic arch, is my preload adequate? So if you have issues with pulmonary blood flow, if you have hypertrophy, if you have a diastolic disease like tamponade or pneumothorax, that could be a problem. And then do you have structural issue that you need to have your cardiologist there with you to support your management? So systolic function, there's many ways of reflecting these different components of the LV function, systolic function and contraction. So we've classically used shortening fraction, which is actually looking at only one angle through one cut of a 2D structure, of a 2D plane. So we'll look at the end diastolic diameter versus end systolic diameter. There's many weaknesses to this M mode measurement. We're going to talk about ejection fraction. We're going to talk about a bit MAPC and this marker, which is the velocity of circumferential fiber shortening. You should know about it because it's been reported in the TNE literature, especially early ages of the TNE literature. It's been mostly abandoned, to be honest. It's not something that's been used that much anymore. So what is shortening fraction? It's basically the LV end diastolic diameter minus the LV end systolic diameter divided by the LV end diastolic diameter. It does access only one slice of the heart, which is just around the basal area / near the papillary muscle. So it's at typically the tip of the mitral valve. It is influenced by septal motion. So if you have like for example, septal dyskinesia or RV hypertension that's causing LV to be paradoxically moving, or if you have any other problems with your septum, like a big VSD or other issues like that, then it really will not provide you a great estimate of your underlying inherent cardiac function of the LV type. It is geometry dependent. It's only providing some aspect of the circumferential contraction, and also your LV dysfunction may be very related to apex problems or segmental problems of the muscle and not necessarily be reflected at only that level of the left ventricle. Typically, we like values to be above 30%, but some literature will tell you that less than 28% is reduced and more than 38% is hyperdynamic. So how do you do it? You can do it both in parasternal long and parasternal short axis. It's typically by putting a line of interrogation at the tip of your mitral valve. So you want to be aligned about mid cavity of the LV, and you want to have your septum, and you want to have your posterior inferior wall, and you want to be at the tip of your mitral valve. And ideally, you want to have a component of your RV body also in the M mode. And so we typically will measure the end diastolic diameter. So you can see here that this is the end diastole, which typically will coincide with your QRS if you have ECG gating. And then you look at the peak of contraction or peak of systole. So you look at your diameter at the peak of systole, and it's basically the ratio of that. So you see internal diameter in diastole is 5, internal diameter in systole is 3. And so if you do 5 minus 3 divided by 5, you get a percent shortening fraction. Are you guys still here? Is it clear? Yeah? Okay, perfect.
Yeah, it's clear.
You can also do that in the parasternal long axis view, where you would put your line ideally as uh, uh, you know, ideally like through the tip of your mitral valve. But you can see that if your parasternal long or short axis is not taken at a cut that is exactly giving you your ascending aorta, your LA, your descending aorta, and your LV posterior wall and septum, and because your heart might be shifted in the chest, if there's a pneumothorax, a CDH, or if basically you have poor windows, you might be cutting your LV in a place that you're not well angulated. So you have to be very careful. And so that's why, for example, ASC in the pediatric and adult world, they even measure it in 2D. They don't even use M mode anymore because of these angle dependency of M mode. But here's an example where you would see your LV, you have your aorta, you have your ascending aorta, you have your LA and your descending aorta. If you have this view, then you could technically use it. And ideally, you want to be angulated where you see some of the body of your RV, which is here, and you see your internal diameter and your both in diastole and systole, so at the QRS and at the peak of contraction. So there are normative values that have been published. They're here. You can use M mode not just for shortening fraction, but you can use also to calculate hypertrophy. So you would look at the wall of your posterior wall in diastole. So when it's completely filled, how thick that is. So we call this the left ventricular posterior wall diameter. You can also look at the septum, and there are equations to combine these things and get an estimate of like the mass of the left ventricle. Although you can see how crude this is when you're just cutting the left ventricle in one 2D plane and actually one single dimensional plane, you're not even accounting for all of this. So you could have a lot of bulky muscle at the level of the apex and very thin wall at the level of the base, and you would never be able to account this on the M mode. So that's why it's a very imperfect way of quantifying this. So that's the example of the 2D methods that ASC has been recommending. And they show you the difference between what you would get through an M mode versus what you should actually be measuring when you're doing it using the 2D method. Ejection fraction has been classically used as the gold standard of systolic function. Um, Now, as I mentioned, it's very easy for a left ventricle to empty against very low afterload. So if there's like torrential mitral regurg, it's very easy for the LV to send everything backward. Similarly, if your aorta is with very, very low vascular resistances or that the afterload starts dropping, for example, if you have a hemorrhage because your aorta is transected, then your LV is going to be contracting very well. But then if you increase your SVR or control your hemorrhage, then your LV may be facing very high afterload suddenly and may start failing. So these metrics are always to be put in consideration of what's the overall status of the patient. If the patient is profoundly hypotensive and on echo you have a very hyperdynamic LV, well, it kind of tells you in your background of your mind, this is probably because my SVR are very low and I need to rise my SVR. But if your patient is super clamped down clinically, very cold, you put a probe and you have a very terrible ejection fraction, well, it tells you there's probably inherent issues with the LV contractility, and I need to figure out why and how can I support this LV. So do I need to correct the acidosis? Do I need to provide inotropic medication to support my LV? Do I need to act on the SVR to try to decrease them a bit? So it's all these questions you have to keep in mind. So ejection fraction basically tells you that you have two volumes. So the end diastolic volume. So that's really a 3D reconstruction because it's a volume, like a milliliter. So it's the capacity of the LV when it's the peak of filling compared to peak of systole. All of this divided by your end diastolic volume and expressed in percent. Most mathematical models by 2D echo use the assumption that the LV has a bullet geometry, which may not be true in all the states. For example, if you have suprasystemic pulmonary hypertension, it's not completely true. If you have LV that has an abnormal configuration, it's not going to be true as well. And don't forget that EF takes only 2 time points in the cardiac cycle. So you might be able to fill very nicely and you might be able to compensate for areas that are not very well contracting because other areas are overcompensating. So think about, one spot in your LV that's been completely necrosed, but all of the other areas around it that are pretty healthy, then these areas might, really compensate and try to contract more. And so you might have a preserved EF, but you have segmental issues. And so that metric won't provide you this information. So there's multiple methods, multiple mathematical models over the years that have been designed to try to express ejection fraction by 2D echo. Ideally, if you do 3D echo or if you're doing MRI, you can reconstitute all the segments of your RV and you're able to truly get a better estimate of these volumes. But what we typically will use is what we call the Simpson's biplane disc method. So you'll use the apical 4-chamber view, you'll use the 2-chamber view, so they're complementary orthogonal planes, and then you'll be tracing these ventricles at the endocardial border, and basically you'll get a volume of end diastole and systole in 4-chamber, and diastole and systole in 2-chamber, and mathematically these areas will be divided into discs. So if you're doing only a 4-chamber, it will assume that all of these discs are perfectly circular. But when you also combine it with the 2-chamber, it will actually take the corresponding disc and create the oval that it represents. It will stagger all these discs together and actually provide you a 3D rendering of the amount of volume in milliliters. So then you can do an ejection fraction for just these parameters in 4-chamber. So that's why you have an EF for 4-chamber. You can do the same thing for 2-chamber where they assume these perfect circular kind of discs superimposed on one of another. So that's in 2-chamber, you get an ejection fraction in 2-chamber. And when you combine all of these discs with these equations, you can also do what we call a biplane method, which is the gold standard that we've been using by echo for many decades. And you get an ejection by Simpson biplane, which is 67% here. Above 55 is generally considered normal, although typically neonates will have much higher ejection fractions than the pediatric or adult population. There's new techniques that have been described to try to account for different geometry of the left ventricle. So for example, in tetralogy of Fallot or some of these CHDs, they'll sometimes use this different technique. What is this different technique? Is that we take a mid-papillary cross-sectional view of the LV. We compute the area at the peak of systole and the area at the peak of diastole. Sorry, peak of diastole, peak of systole. So the peak of filling and the peak of contraction. Typically, the peak of filling is during the QRS because it's at activation that eventually you start contraction into your isovolumetric contraction time. And so you take this area, you multiply by the length of the left ventricle, you multiply by 5 divided by 6, and it's going to give you this assessment of LV-EDV. You do the same thing, so the length times the area times 5 divided by 6, and you get systole, and then you can compute your ejection fraction using this technique. And it was initially described using the subcostal short axis view because in many patients, sometimes you can have difficulty accessing the chest. And so in the congenital heart defect population, sometimes they have open chest or, chest tubes, drains, pleural effusion or effusion, and it becomes difficult to assess the heart from these views. So they designed this to be visualized in the subcostal view as well. Finally, the MAPC, I think some of you have heard of that. It's the correlate to the TAPC. It's the mitral annular plane systolic excursion. It's basically the distance that the mitral valve traveled in systole towards the apex. So you need to have a line of interrogation through the apex of your LV and at the attachment of the mitral valve to the free wall of the left ventricle in the apical four-chamber view. And what you can measure is the distance that is actually traveling, which is the same as for the TAPC on the RV side. The problem with this metric is that we just said that the LV has a very small contributor of longitudinal contraction. And because of that, it's not been a marker that has retained a lot of attention or popularity, but it's an easy one to obtain. And maybe in the literature of point of care ultrasound, it's something that will become interesting for users that don't have as much experience to quantify LV function. There's been normative values that's been described. You can see the numbers, very tiny populations. And it only targets, smaller areas of the ventricles. So it doesn't tell you a global function of the LV. I'll finish with the TDI because we only have a few minutes left. What's TDI? It's basically using the capacity of Doppler to compute the speed of how the tissue is moving. So as I just mentioned, the tissue is moving. So there's a distance it travels, but there's also a speed at which it performs this distance. Okay, so a car could be traveling 10 kilometer and it could travel the 10 kilometer by 100 kilometer per hour, or it could travel the 10 kilometer by 2 kilometers of an hour. And it's going to take much more time, but it's still going to do the same distance. TDI tries to assess this speed. And the idea is that higher speed are probably associated with more vigorous left ventricles. So you would see very high speed in patients who are, for example, in a hyperdynamic state. You would see normal speeds in a patient who has a normal state with normal cardiac function. And you would see a lot of dampening of these speeds if basically you have some degree of cardiac restriction in motion. So the TDIs looks like this. You get a portion in systole, which it's on the positive aspect. So here you see the velocities are on the y-axis and you have time on the x-axis. You even have your what we call your sweep velocity here, which is like how compressed your signal is. Here it's at 67, here it's 100 per second. And what you have is it's exactly like Doppler. Doppler is going to be red when it comes towards the probe, and it's blue when you go away from your probe. And by definition, whatever is towards your probe is positive, and what is away from the probe is negative. And so in systole, your LV will come towards your probe in the apical views, and so you have positive deflections. While in diastole, you get LV re-expansion, and basically your LV is going away from your probe, and you get negative deflection. And so you get what we call a systolic phase. So you can get a peak velocity of the systolic phase here. And then you get diastolic velocities. So you get typically an early phase and an active phase. So early during the passive re-expansion when the mitral valve opens, and then the atrial kick during atrial contraction. And this can be obtained both at the lateral wall of the left ventricle or the septal wall. And it's typically by putting your pulse wave Doppler in a TDI mode. So it's still a pulse wave Doppler in the sense that it obtains those velocities exactly at the point of interrogation. And so there are normative value. And you can see here how this velocity is much more dampened than this velocity. So here we would suspect maybe this patient has some degree of LV dysfunction depending on normative tables. And then you can see that there's probably some degree of high frequency oscillation here. hence the artifacts. So this is your systolic velocity, S prime. This is your early phase, which is a diastolic component, and atrial phase. For the diastolic component, I won't get into that today. We'll talk it at another time. But for the systolic phase, there's been tables looking at normative values. And one of the component of cardiac function that we rarely compute at the bedside, but more and more it's being used in some of the oncology literature for subtle dysfunction or to follow post-anthracycline administration. As well as you'll see that in research format is something called the myocardial performance index. It's also called the TIE index. And what's the myocardial performance index? It's basically, it incorporates the time you spend in isometric contraction, the time you spend in isovolumetric relaxation, and the ejection time. And so how do you measure that? Well, basically, when you finish your diastolic motion, you have a component of you have a time that you spend in isovolumetric contraction before you start ejecting and your ventricle starts going down. Then eventually it stopped doing this, and then you have a component of what we call isovolumetric relaxation, which can be seen here, just before you start having your re-expansion. And so it's basically how much time you spend here, how much time you spend here, divided by the time you spend in ejection. But because you don't want to do 3 measurements, because you increase the amount of error mistake if you do 3 measurements, what we typically do is we'll measure from here to here. It's going to be A. And then we measure ejection time only. It's going to be B. So if you do A minus B divided by B, which is your ejection time, you get exactly this equation, and you get what we call the MPI. So this is A, which is the ejection time, or A, which is the ejection time, and B, which is the all the component of IVCT ejection time plus IVRT. And so you can do this for the TIE index. And there's a lot more research going on with TDIs to try to see if you have early predictors of adverse outcomes. So you can do this also using what we call the pulse wave Doppler. And what's the pulse wave Doppler is actually the inflow-outflow velocity in the kind of 5-chamber view. You go at the intersection between the red and the blue, red being the filling of your LV, and you can see that swirling and going towards the LV cavity, the LV outflow tract, eventually into the aorta. And so you put your cursor at this intersection and you capture a bit of the flow going towards the aorta, the flow when you have this filling phase of the LV, and you see this where my arrow is. This is the time you spend in isovolumetric relaxation time. And here is the time you spend in isovolumetric contraction time. So it was the old technique to calculate the MPI, which is something we don't use anymore because you get much more granular information from the TDI. And I've put this here, it's exactly the same representation. So you'll go on your Cardiolab normative value and you'll see that there's been normals that's been described for S prime, IVCT, IVRT. And there's been also normals described for the MPI. And the MPI, what's important to remember is that it's a combined marker of function that combines diastole and systole because you have the isometric relaxation time included in this fraction. And basically, you can see that it's a range, and the 2 extremes of it are informing you that something wrong is happening. This has also been described by the group of Dr. El-Kufash from Ireland in preterm cohorts at the first week of life plus 36 weeks and in healthy term. So you have here all these parameters for the left ventricular free wall, septum, right ventricular free wall. And so if ever you have some of these patients that you would want to see if there is something that looks abnormal, you can look. This is a preterm cohort of healthy cohorts of preterm infants. We already described the DPDT of the MR. I'm not going to go again over this. Ventricular output, we also described it. We spoke about the fact that 150 to 400 cc per kilo per minute is usually the normal, but some patients, they have decreased metabolic rates, so you have to match it to the clinical status, like a cooling, for example, that's doing nothing or is on tons of anti-seizure medication and almost comatose, has really decreased metabolic demand. So the heart may be adapting by decreasing heart rate, for example, or even the cooling process will decrease heart rate. And so it's not infrequent to see that some of these patients have 100 cc per kilo per minute easy. And we usually, as you know, use an estimate of stroke volume times heart rate divided by body weight at the time of the echo. And so the stroke volume is a component of using the diameter of the LVOT that we'll typically measure in the parasternal long axis view. Plus, we take a pulse wave Doppler at the LVOT and we trace the VTI. And you can see that VTIs here is basically an estimate of stroke distance. Basically, that provides you with eventually, if you multiply this by the heart rate times the cross-sectional area of your LVOT, you can calculate your LVO. So I see it's 3 p.m. and I'm going to have to go for my next meeting, but I've put here a few examples, but you can see many on the website under the LV function tab. And so this was really for how like broadly assess LV function by TNE. Any questions? That's by 2D. One day we'll speak about strain again, because we started addressing it last time, and we'll speak about 3D, which are new metrics. But now there's also like assessment of vorticial flow and all these kind of myocardial work. So there's a lot of things coming up down the pipeline to better discriminate patients who have dysfunction, on top of the whole diastology world, which is something that is really under kind of investigation. But I think for clinical purposes of TNE, like what you have to measure is typically your LVO, your ejection fraction, your shortening fraction. And I hope I was clear enough to explain why we measure these things in a sense, some of which look normal and some of which could be abnormal. So you have to kind of do a package and make yourself like an idea. And then based on that, you can decide what are going to be the strategies to revert that. Perfect.